Welcome to the Department of Medicine Grand Rounds. Today is a particularly special one because it represents the annual Helen Rainey Lecture honoring a pioneer in our field, and is the first Rainey Lecture to take place under the auspices of our newly minted Division of Hematology and Cellular Therapy. The Rainey Lecture is an annual event for the division in the Department of Medicine, during which a prominent hematology expert gives a seminar on a subject of medical importance to specialists, generalists, and students alike. This year, the Rainey Lecture will be given by Professor Naval Daver from the MD Anderson Cancer Center. But first, I'd like to begin with a few words about Dr. Helen Rainey, a physician scientist and a giant in the field of hematology and medicine. Helen was born in 1920 in Sumner Hill, New York, where her parents ran a dairy farm. She attended a one-room school as a child and was a graduate of Barnard College and the Columbia University College of Physicians and Surgeons. During subsequent faculty positions at Columbia, Albert Einstein, and SUNY Buffalo, she developed an international reputation for her research related to hemoglobinopathies, eventually leading to her election to the National Academy of Sciences. For the hematology nerds in the audience, she pioneered the simple paper electrophoresis method of separating hemoglobin variants, proving that hemoglobin S and C were allelic variants of the same gene, years before Vernon Ingram and others identified the single amino acid change that defined hemoglobin S. Most importantly for us, she was the first female chair of the Department of Medicine at UCSD beginning in 1973, and the first female chair of a Department of Medicine anywhere in the country. This is one of her many firsts, as she later became the first female president of the American Society of Hematology. And I had the good fortune of working with her as a medical student here, and actually she even hired my wife to work with her group in her company, Alliance Pharmaceuticals, when they were developing perfluorocarbon and cell-free hemoglobin alternatives to red blood cell transfusion. Helen passed away in 2010 at the age of 90, truly a remarkable woman of many firsts. Today's Rainey Lecture will be presented by Dr. Naval Daver. Dr. Daver received his medical degree at the Grand Medical College and Sir J.J. Group of Hospitals in Mumbai, India. He went on to complete a research fellowship, followed by a clinical residency and fellowship in oncology at Baylor College of Medicine in Houston, before being appointed to the faculty at MD Anderson in 2011. Dr. Daver is now a professor in the Department of Leukemia at MD Anderson, and where he also serves as co-section head for AML. These titles greatly underestimate the contributions he's made to the clinical care of patients with AML and related disorders like MDS. Dr. Daver is an internationally renowned expert, not only in the care of patients with heme malignancies, but in the clinical development of novel agents for these conditions. Throughout the years, he's led dozens of innovative clinical trials that have resulted in multiple drug approvals in a field where the standard of care had remained largely unchanged for decades before. I remember first meeting Naval at a wonderful AML meeting in Munich when we were both junior faculty members and both the beer and the science flowed freely. And since then, I've had the pleasure of working with him on multiple occasions in a variety of contexts, and every time he speaks, I learn something new. Therefore, it's an enormous pleasure for me to introduce Dr. Daver to you today to present his Rainey Lecture entitled Focus on Targeted Therapy-Based Combinations in Frontline and Relapsed Refractory AML.
All right, well, thank you very much to Dr. Behar for the extremely kind introduction, and it's a great honor and pleasure to be here to give this Rainey Lecture, and thank you for having me. So AML, actually, for the first time or in many years, we can start saying there's actually a lot to cover in AML. So it's not like 2015 where we could probably give this talk in 10 minutes. There's a lot happening. In fact, at ASH, when we had the symposium for the first time, there were more people who went to the AML symposium than myeloma symposium. So for residents and fellows, it's a hot area if you're interested, and a lot of new things happening. So I'm going to try to focus more on targeted therapies and cover 4 or 5 key concepts. It's kind of slow. Try to the mouse? Yeah, that's fine. You can do that. Oops. Oh, there we go. So these are my disclosures. We have a lot of ongoing trials, investigator and sponsored studies, as well as a lot of advisory consulting with many different companies in AML. I'm going to do a little bit of background because Dr. Behar told me, there's a wide spectrum of audience here, residents, fellows, faculty, experts. So firstly, AML is not a homogeneous disease. I think that's probably the most critical message here for residents and fellows. It has a variety of different molecular mutations and aberrations, which have a great impact on the prognosis of the disease, how it behaves, as well as response to therapy, as well as how we tailor treatment approaches, including transplant, selection of intensive chemo, low-intensity therapy. Now, of those various mutations, the 5 that are most important because they have entered the therapeutic arena are FLT3, IDH1, IDH2, and now with the menin inhibitors, NPM1 and KMT2A. But a lot of the others also have prognostic importance, can be used for MRD tracking, and potentially modulate our therapy. So this is very important. And just to give an example, I'm not going to spend a ton of time on this, but there are many publications that have shown that certain mutations can greatly impact the outcome of different AML. So if you take an example of acute promyelocytic leukemia, which is an AML-M3 subset, which has the AML-RAR, the outcomes can be close to 90-95% survival without chemotherapy. So this is the best subset, not just of AML, but maybe one of the best outcomes in any malignancy in the world. But then if you go to the other extreme, if you have a patient with TP53 biallelic disease complex karyotype, and historically KMT2A, although I think that curve is going to move up quite a bit with the menin inhibitors, the outcomes can be up to 10% in 5 years, very poor. So when I get an email or a phone call, which we get a lot, saying I have a new AML patient, 48-year-old, what should we do? It really is not a good answer because we're talking about almost 6 or 7 different entities of AML based on the underlying molecular features, cytogenetics, and the treatment approaches for those. So I think that's the first important thing. Whenever we're talking about an AML patient, the key factors are age, the cytogenetics, molecular features, and if this is a de novo AML, therapy-related AML, that helps us to start focusing our thoughts on prognosis, treatment, and how we're going to approach this patient from the first interview with the patient. Now, genomics are very, very important to improve AML therapy. I think this is where we've made the maximum progress in the last 9 to 10 years. We now have a number of different targeted therapies. I'll go through those in more detail, but FLT3 inhibitors, 3 of them are approved. Quizartinib, ibrutinib, and midostaurin, IDH. We have both IDH1, 2 of them approved, ivosidenib, olutasidenib, as well as IDH2 inhibitor, enasidenib. And then menin inhibitors that target 2 common aberrations, the NPM1 and the KMT2A rearrangement, but actually probably will work in other fusions, rearrangements that we're starting to identify, UP98, UDTF, and maybe impactful in up to 40-50% of relapsed AML, we believe, are now becoming more and more prevalent. 2 of them are approved, others in advanced development. There are certain molecular subsets for which, in spite of a lot of ongoing efforts and research, we still have not been able to achieve great improvement. TP53 is unfortunately one of those. There have been a lot of efforts with immune therapy, CD47, SIRT-alpha antibodies, APR, but so far the outcomes have not changed. The standard remains HMA or HMA venetoclax. And then RAS, there's going to be new RAS inhibitors coming later this year. We're very excited about those. It will take time to figure out how they work, etc. But I do think we're going to have RAS targeting therapy emerge in the next couple of years in AML. So this is a long list. I don't want to go through each of these because we'll talk about them in the respective sections, but just to show how much has happened in the last 7 to 8 years, we now have 14 FDA approved drugs, including the 2 menin inhibitors that just happened within the last 1 year. And so this is great, but it also creates some degree of confusion and complication in how we use these drugs. And I think a lot of that, unfortunately, is going to continue until we learn more and more about these various agents, how to combine them, how to use them, how to sequence them. But it is becoming very much like multiple myeloma, where a lot of new drugs are coming quickly, and sometimes we're not able to do full randomized studies to answer as many questions that are emerging. This is kind of a general roadmap for AML. It's kind of pretty much still relevant. I think the menin inhibitors will be added to this in the future. In the frontline setting, we look at AML based on the underlying cytogenetic molecular, as I mentioned. So for APL, we do the alpha arsenic for core binding factor, which is an important group, inversion 16, translocation 821, about 15% of AML. Addition of gemtuzumab to backbone intensive chemo can give you 80% or higher long-term remission rates. And then for the FLT3 mutated groups, we add the FLT3 inhibitor to intensive chemo. For all the others, the standard is still either 7+3 or FLAG-IDA. Different groups have used different backbones. There is data emerging, potentially adding venetoclax. In fact, now that's on the NCCN guidelines, using FLAG-IDA or clear venetoclax, potentially improving outcomes. And then in the older unfit, similarly, we'll talk about azacitidine venetoclax as the established standard, but how we can improve on that with addition of targeted therapies. And then the one group that still should really go on clinical trials for all patients, regardless of age or fitness, is the TP53 mutated, where we still need to find new treatments and options. So let's talk about 4 of those important groups: FLT3, IDH, KMT2A, and then importantly, where aza-ven is today and where it may move in the future. I think FLT3 is a very good one. It's kind of like the poster child of outcomes in AML and how we think other targeted therapies will work. So this is the data from about 20 years ago, 2002, the German group published outcomes in newly diagnosed young FLT3 mutated patients. As you can see, even in the young patients with traditional intensive chemo, FLT3 ITD on the right, the overall survival was 20% at 5 years. So this was, at that time, the ELN considered to be adverse risk. Now that has changed. It is now intermediate to favorable because of the FLT3 inhibitors, as well as improvements in stem cell transplant. The FLT3 inhibitors probably have had the maximum impact in the frontline setting among targeted therapies. It is important to note that these drugs are not all the same. So there's a group of FLT3 inhibitors that are called the type 1. Importantly, they cover both ITD and TKD, so the two common types of FLT3. There's another very potent group of drugs called the type 2 FLT3 inhibitors. Quizartinib is the poster child in that group, which covers only ITD, but that is fine because ITD is 80%. So if you have an ITD mutation, quizartinib is a good option. Gilteritinib is still reasonable. But if you have only TKD or ITD with TKD, we may start leaning more towards the type 1 inhibitors like gilteritinib, midostaurin. So it's important to just know that you have to look at the specific type of FLT3 mutation to know which drug you're going to use. All FLT3 inhibitors will not cover all FLT3 mutations. Now, we're not going to go in detail through all of this, but there have now been at least 7 randomized studies, 2 of them in the frontline setting, quizartinib, Quantum First, and the Ratify midostaurin study, 3 in the maintenance, actually, 2 of them with sorafenib, 1 from Germany, 1 from China, and a recent one called the Morpho global study of gilteritinib maintenance post-transplant, and then 2 in relapse. And all 7 have actually shown improvement in outcomes. So it's very clear that the FLT3 inhibitors work. They work in all settings. They work with the induction, they work as a maintenance, and they also work in the relapse refractory setting. Although the maximum benefit seems to be when you use them earlier on with induction or maintenance and relapse, even though they do work, the outcomes still remain poor. So you want to use them earlier on. This is now reflected in the NCCN guidelines, where FLT3 inhibitors are recommended, which means you have to check for FLT3 for all of your patients at new diagnosis. If they have a FLT3 mutation, you add a FLT3 inhibitor. It could be either midostaurin or quizartinib. There's a lot of discussion, debate in the community, which is better, which is not. In our opinion, and many of the sites in the US who have done these trials prefer quizartinib. It seems more potent. It seems to have a better outcome in the 60 and below patients. Tolerability is good, does not have the GI side effects. And in general, we have moved towards quizartinib for the ITD. Now, if they have a TKD, then I think midostaurin is a reasonable option. This is just looking at some of the data. I think one of the issues is, of course, these studies were not exactly the same. So on the left, you have the Ratify study that looked at midostaurin added to backbone intensive chemo versus placebo intensive chemo. And this study only took patients 18 to 60 years of age. So in that study, in that population below 60, the 4-year survival was about 50%, which is good compared to 20-25% when we started. With the Quantum First, it allowed patients between 18 to 75, so a broader population. But when you compare 18 to 60 years of age population, which was 60% of the study, so the majority of the study, the 4-year survival seems to be better. Now, this is not randomized, it's not head-to-head, they're a couple of years separate in time, but based on this and also based on our clinical experience tolerability, we are preparing quizartinib in the frontline intensive chemo. Now, that being said, the Quantum First showed us some interesting and important data in the older population, above 60. And here you can see that there's no clear benefit of quizartinib. This is about 40% of the entire study. So it's a subset, but a pretty reasonable subset. And the median survival is only about 17 months. So we feel that in the above 60, and especially above 65, there may be a role to start moving towards other backbones. Intensive chemo may not be the optimal one. There's still a lot of early toxicity and mortality. Role of transplant in FLT3, this is also something that is being discussed. There were a lot of presentations at ASH. Should we transplant all frontline FLT3 ITD? Can we select those who may not need transplant in CR1? I think that's a question research arena, and we're looking at it with NGS MRD-based data. But I would say today, the general recommendation is for FLT3 ITD, we will still consider transplant in CR1 for patients below 70, 72 who have a good donor and are transplant candidates. And this is what was shown from the Quantum First, that even after correcting for other variables, the 2 factors that seem to clearly improve survival outcome were the FLT3 inhibitor and a very high impact of allotransplant in CR1. So that is still the general broad recommendation. Of course, there are caveats, and there are certain patients who achieve NGS MRD negative or above 70 may not have a donor. we can look at those individually. What about post-transplant? So you've given induction, consolidation, you've achieved a good remission, hopefully MRD negative, taken transplant after 2 or 3 cycles. Are we done? There's now data to suggest that maintenance post-transplant with single-agent FLT3 inhibitor may actually improve outcome. There's data with gilteritinib as well as with the others, but the gilteritinib data was the strongest based on randomized phase 3 post-transplant maintenance dedicated study. Even in those who cannot go to transplant, maintenance is actually probably even more important. So if because of age, economics, distance from transplant center, no donor, patient preference, they cannot go transplant, even in spite of that being a recommendation, then using a FLT3 inhibitor added to induction consolidation and then continuing maintenance with the FLT3 inhibitor for 2 to 3 years was shown to be beneficial in terms of both event-free and overall survival. And quizartinib is the one that is recommended by the FDA and NCCN for that setting based on the degree of survival benefit. This is just showing the post-transplant maintenance study called the Morpho study, which is a randomized phase 3 study of gilteritinib versus placebo in patients who had a known FLT3 ITD, then went to transplant. And what you can see is, even though the overall study, the benefit is not as clear, the p-value 0.051, but it looks like there is benefit. But those who had a FLT3 detectable using a sensitive NGS minimal residual disease assay were clearly benefiting. So we are doing this now, both pre and post transplant. We check for the NGS MRD assay. It has a sensitivity of 1 in a million. And if it is positive at any level, 1 in a million or more, we are giving gilteritinib maintenance. And this is improving the relapse-free survival as well as the overall survival to some extent. So now putting it all together, over the last 20 years, since we first identified FLT3 and found that the survival was only 20-25%. At that time, it was in the adverse group in the ELN, using the FLT3 inhibitors, transplant in CR1, now post-transplant maintenance FLT3 for those who have detectable FLT3 by NGS or PCR-based assay is starting to improve the outcome. In our most recent data of 2023, we're seeing the 3 to 5 year survival now close to 65-70%. So this is a great improvement. Of course, we can improve further, but this is kind of one of the groups where even the classifications have changed from adverse to intermediate. So some of the FLT3s potentially, if they are NPM1 with low FLT3, could even have a favorable outcome, and that is good. Now, what about those patients who are above 65 or even above 70, where intensive chemo may be difficult in certain scenarios, depending on comorbidities, other factors? So here it's very important to mention this seminal study called the azacitidine venetoclax combination through the VIALE study. This was actually led by one of my colleagues, Dr. Leonardo M.D. Anderson. It was a global study. This looked at azacitidine plus venetoclax versus placebo azacitidine, which was the standard at that time. Azacitidine alone had been the standard for 15, 20 years. And the goal here was to show that adding venetoclax to that standard backbone of azacitidine will improve your outcomes in terms of survival, response, and other parameters. This study was mainly for patients who were either above 75. So if you're above 75, you're automatically considered not a candidate for intensive chemo, which is generally true. And below 75, if you had a major comorbidity, cardiac, renal, or other, then also intensive chemo becomes difficult with high risk, and azacitidine venetoclax could be used. So the study overall did show a benefit in terms of survival. This was the readout of the study with the long-term follow-up. But what we were all disappointed is that even though there's a survival advantage, the long-term survival still is limited. So the 3 year overall survival is 25% versus 10%. So that's better, but it's still only 25%, and relapses continued beyond 2 years. So we need to improve on azacitidine venetoclax is kind of the story that's emerging. Now, for many of the fellows and others who use aza-ven, there's a lot of tricks to the trade. Unlike FLT3 inhibitors, it's not a therapy to start and give. You have to know how to do it. This is a paper we published, How I Treat, because we were getting so many emails and questions, and there was so much heterogeneous use. So I think in general, using venetoclax for about 21 days or so in the cycle 1, using a TLS prophylaxis, monitoring patients closely, either inpatient for a few days and then close outpatient or inpatient, and then also using growth factors now earlier and earlier, once you have a marrow showing remission, are some of the things that are showing benefit. So you can look at this, and we tried to make this very practical so it can be applied in the clinical setting, and a lot of people thought that that was helpful to them. But what do we do beyond the standard today azacitidine venetoclax for this older unfit population. One of the other important data sets that's come out is how much venetoclax. And this is something that with the Project Optimus in general, the FDA is becoming very focused on, appropriately so, because we were giving 28 days of venetoclax. That was kind of based on preclinical data as well as the idea that you needed continuous therapy with venetoclax. But now recent data from the French group shows that even 7 days of venetoclax, they did a study called 7+7, 7 days azacitidine, 7 days venetoclax, and they actually showed very similar remission rates. We compared it to our MD Anderson data, which was usually 21 to 28 days of venetoclax, like the US label. And you can see the overall survival seems similar. In the bottom, you see these different subsets. So the MPR is high is patients who have NPM1 IDH. There, more venetoclax seems to help, which makes sense because they're sensitive to ven. You give more ven, it does help. But for the intermediate and low, which is basically TP53, FLT3 RAS, where venetoclax is not very sensitive, giving more ven may not help. You may actually get more benefit from adding a targeted therapy, just giving 7 to 14 days of ven, not 28 days. So this has led to the concept of maybe developing targeted therapeutics, adding to HMA ven, what they call the triplets now. And there are a variety of these, and each one is different in terms of the safety, the tolerability, how much you can deliver, and what are your expectations. So IDH, FLT3, and menin are the 3 big ones, where adding a targeted therapy to HMA ven makes practical sense and is being evaluated in clinical trials. And then in the future, hopefully looking at RAS, TP53 with some of the immunotherapies and RAS inhibitors. And the idea here is, can you improve on each of these subsets based on what you know you can achieve with HMA ven in each of those molecular groups. Now, when you develop these combinations, this is not simple 1 + 1 + 1, just like if you do it in myeloma or ALL, you cannot just add full doses of each drug. You will get a lot of toxicity. So we started these triplets 2 years ago with a lot of communication with the FDA and a lot of dose optimization, looked at different dose levels, eventually found that 14 days of venetoclax, 14 days of gilteritinib or quizartinib was sufficient. We tried to give 21 days of ven, and we tried to give continuous FLT3. It was very myelosuppressive. So this ended up being the optimal tolerated dose, but also highly efficacious dose. And then for subsequent cycles, we further reduced the ven to 7 days, and that seems to be well tolerated and maintaining a deep remission. So it's important as we move into these combinations to make sure we're not delivering too much of any of the drugs that will cause prolonged myelosuppression. Now, we were discussing yesterday at dinner, the frontline versus salvage data. I'm not showing much of salvage data because salvage data is not very good. In general, salvage in AML is a very difficult bar, and it's hard to really deliver these therapeutics, especially combinations, because you're starting with a very myelosuppressed population. But the frontline data is what we are most excited about. So this is the frontline data, aggregate data of azacitidine, venetoclax, FLT3 inhibitor. We pooled the quizartinib, gilteritinib, 2 different studies to get a broader data set. And we can see here that when you compare to the published data of aza-ven in FLT3 mutated, which was actually published by Marina Konopleva, who was at MD Anderson at that time, you see that there is an improvement in all the parameters. So the CR rate, most strikingly, is better, 82 versus 32%. CR/CRi is also better. And then the survival here is close to 29 months versus what was published with aza-ven in 2022 of about 12.5 months, as well as 2-year survival. So we think that with this approach of the curtailed venetoclax, curtailed gilteritinib, we're getting good responses, we're getting good durability, and it seems like maybe a better option in the frontline space. Now, the concern has always been myelosuppression, even with the 14 days. We're starting to find that that is manageable with a count recovery of about 35 to 37 days, which is not that different with aza-ven, as well as low induction mortality. But again, this is done in big academic centers, so I don't think this is something I would recommend or do in the community, but I think in academic centers can be done well with close monitoring, use of growth factors, etc. Of course, this was an MD Anderson IST, so we wanted to see if this could be replicated. This led to what we call the Viceroy study. This was a multi-center study, about 20 different sites. Dr. Hodgman from Northwestern presented this data at ASH just last month. And the design was exactly the same, using the MD Anderson regimen, venetoclax 14, gilteritinib 14 days. You can see the population is truly older population, median age of 73 to 77, and majority of these were FLT3 ITD. And it was really good to see that we're getting almost the same remission rates as was seen in our study from MD Anderson, close to 91% CRC, full CR rates of 70%, and remissions were happening quickly within one cycle. And most importantly, the survival here is continuing to look good, around 24-month median survival, similar to our MD Anderson data set. So this data supports further use of triplet. The study is being expanded. We're discussing with the FDA further directions, but I do think with this, there's going to be a more uptake and use of this in the optimal dose adjusted setting for FLT3 mutated. Now, that being said, a lot of people started saying, well, the data, is so good in the Anderson data we published in JCO, now the Viceroy data. Do we need to give intensive chemo? I mean, is this regimen like myeloma with proteasome inhibitor and steroid and other agents IMiDs that you don't need intensive chemo? Can you get rid of it? We don't know, but there is one important study shown at ASH from Amir Fati. A lot of credit to him for running this very major study. It was an investigator-initiated study. It took a long time to get all of the support to do it, brought 10, 15 centers on, and really great he could do it because I think it's a very important study. And what they looked at was the question many of us have been having for many years is that is Aza-Ven in a position to replace intensive chemo such as 7+3 CPX? They randomized 1:1. There was 170 approximately patients, and patients received the standard approach with Aza-Ven and or 7+3 as you would do. Now, there's a lot of excitement with this study, but there are a few important things we must highlight. One of them is the exclusion. This is probably the most important thing. So they excluded, and the FDA requested them to exclude appropriately FLT3-ITD because they do well with intensive chemo FLT3 inhibitor, NPM1 below 60 because they can actually do very well with curative outcome with intensive chemo, and also the core binding factor. So that's about 40 to 50% of AML, and those patients were not on the study, and this study should not impact how we view or approach treatment of core binding factor, APL, FLT3, or NPM1 mutated. But for the other 50%, this study is still very relevant and interesting. Now, the other key thing here was the event-free survival. So the way they define the event-free survival is a little different from the traditional FDA definition. The event-free survival here was from the time of starting therapy to switching to a new drug, relapse, or death. So you did not have to achieve a CR or CRH for event. It was just when you started the drug, they started the counter for days. And I think that's okay, although the FDA usually only allows you to be event-free in those who achieve a CR. And then the key factors they found were remission rates, and I think this is to me the most important, more than the outcome of the EFS, because I think that definition and the way it's used benefits HMA-VEN already. But the remission rates were equally collected, and there should not be any benefit for either regimen. You see HMA-VEN gives you better CR rate, CR/CRH rate, overall response rate. Basically, every parameter of remission was better. And also the transplant rate is better. Not a lot of people say why. And I think it's because of two things. One, you have a higher remission rate. So obviously the transplanter is happy. The patient's in remission, they want that. The second thing is you have less toxicity. So they looked at some metrics, but there are probably many other metrics that were benefited, but infection and bleeding were much lower with the HMA-VEN. Early mortality, this was quite impressive actually, was 0 in the 80 patients who got it across 10 centers. So that's really nice. With intensive chemo, it was not too bad, but still 5%. So you have a better response rate, less toxicity, less infection, patients look healthier, less ICU stays. Transplanter looks at them and says, I'm ready, this is good patient, let's move. So I think this is why they had a higher transplant rate, which of course benefited the EFS, but that's fair because, transplant is a factor of response and tolerability to the previous induction. So the primary endpoint eventually was met, event-free survival, that is good. Overall survival was not met. Amir did a good job of explaining the issues there. What they saw is that patients who got intensive chemo, 70% of them got HMA-VEN and salvage. So this diluted some of the benefit, as opposed to that, when patients got HMA-VEN, only 40% got intensive chemo. So there was better salvage option after the intensive chemo that pulled up the survival curve, but the EFS was still bad. Now, this is not a registration study. It was an IST study. It was kind of a hypothesis generating study. It's an interesting study. What do we take away from it? I think, as I mentioned, number one, FLT3, NPM1, core binding, and APL were not included. So this study should not impact anything we do with those patients. The second is this was predominantly older population. So the 70% of patients were above 60, 70% were adverse ELN, which is a mix of therapy-related mutations, TP53 complex cyto, but generally adverse. And there was a high transplant rate. So the way I would see it, if you put all of this data together, is that if you have a patient above 60 who has an adverse mutation and is in a transplant center with high ability to transition patient to transplant, HMA then is probably as good or maybe better with less toxicity to transplant. But for a 30 or 40-year-old who does not have adverse features, I would be nervous. Or in the community where transplant is not happening rapidly, then I would be nervous to use this. And in fact, this is what we do in our practice, 60, 65 plus, if they have adverse features, I want to get them to transplant, I don't want to beat them up, I'm giving them an event. So it kind of confirms a lot of practice in the US. I don't think today it's changing dramatically my practice for younger patients, and definitely not for FLT3 and PM1 or finding character. So so it was about 5 to 6, 4 to 5 cycles later then, and about 2 to 3 intensive chemo. Yeah.
So did they go faster to transplant for the event, or did it?
About the time transplant was about the same. It was just more transplanted because of better remission rates and less toxicity. Yeah. So as I mentioned, these were the exclusions. Majority were older, adverse, and so I think it confirms a lot of what I think our group, your group, and others. Now, Josh and Anderson, and we were actually advisors with Amir on this and helping him from the beginning of the study. Me and Courtney, he reached out to us, and we were happy with the study to go through and supported that. But it also opened now the concept of if you can move down the age and HMA then looks at least as good, whether it's better or not, then maybe adding a targeted therapy or a third effective drug could further improve the outcome in that setting. And so this is an effort we're doing. I'm quite excited about this study. It'll be opening very soon. It's a collaborative effort between the UK and sites in the US. MD Anderson is there, but we have others as well, City of Hope, UNC Moffitt. And we're going to take the paradigm study to kind of the next step. I mean, we've been working on this for a while, but it just so happened that everything has come together now, where we're going to look at AZA, then FLT3 based on the data we've generated at MD Anderson versus the traditional intensive chemo quiz, but not in 18 plus, in the older 50 or 55 to 75. And based on the data we have so far, we believe there's a good chance that the HMA event FLT3 will in fact give us better remission rates, less mucositis, colitis, severe infection, potentially higher transplant rate, and eventually a better survival. So this study will hopefully further build on the paradigm and cover the FLT3 aspect of it, and will probably take a couple of years to get data. Now, a little bit about IDH. I'm not going to go into great detail on that, but IDH inhibitors are available. These also have single agent activity, but limited, similar to FLT3 and salvage. They can give you 30-35% response, but durability is short. OS is usually less than 10 months. So using them as a single agent in salvage is, in my view, not really the best bang for your buck, literally, because all of these medicines are quite expensive. So I don't know if single agent salvage is going to give too much benefit to the patient. Now, combining it in the frontline setting really changed the picture and gave us the best activity with these drugs. So azacitidine and ivosidenib in the frontline compared to aza placebo, this was called the Agile study, showed a great improvement. Median survival, as you see in the bottom, 29 versus 7.5 months. So quite a dramatic survival. This was older, unfit AML 75 plus. So 30-month survival is something we have never seen in a randomized study in that population. Very powerful effect of AZA-IGO. Now, a lot of people say that you have AZA-IGO and you have AZA-VEN. How do you choose? We will not have a randomized study, unlikely in the future because of patent and financial things, but we have data from the two studies. In the IDH1, AZA-VEN is neutral. It's not better or worse. It has about the same outcome as the general population, close to 16, 17 months survival. Also, there's a lot of myelosuppression and tricks and toxicity, and you have to adjust and hold and growth factor. So if I had to choose between the two, especially in the community or smaller, but even academic center, I think AZA-IGO is the one I would today lean towards if I have that data. Now, if it takes me 2-3 weeks to get the IDH1, then the proposition may change because I'm waiting for 100% for the 8% that have IDH1. But if you can get it quickly in 4 or 5 days, then I think it's reasonable to wait and use AZA-IGO when available. Now here as well, our group has been looking at building on that. Yes, AZA-IGO is good, but can you make it even better? Could it be curative, even in some of these older patient populations? So we've looked at AZA-VEN IDH inhibitor. Again, here with the 14 days of Ven as the optimal regimen, this was just published in the ACO, and you can start seeing the survival here at 2 and 3 years is close to 70% compared to about 50% with AZA-IVO. So I think we still need more follow-up here because the survival is already good with AZA-IVO to get confidence, but this may be a future direction as well, where we could improve on both AZA-IVO, AZA-VEN. This actually is something that is now being evaluated in randomized study through HOVON, where they're looking at AZA-VEN-IVO versus AZA-IVO placebo in a large randomized effort with about 400 patients to look at OS, EFS, CR endpoints, and that data will hopefully read out in the near future. And then lastly, I'm going to talk a little about menin inhibitors, which are kind of the new kids on the block, exciting, but early days. And I still think we have a lot to do to learn how to best use them and where to best use them, understand resistant mutations, and how to combine them in the future. So now menin is different from FLT3. So when you use FLT3 inhibitors, you're actually inhibiting a particular receptor kinase pathway. With the menin inhibitors, this is actually an epigenetic therapy. So the menin pathway is part of what we call the PRC complex. That complex, when activated, increases NES1 OXA, and that results in a differentiation blockade. So you basically have premature arrest of cells in the blast phase. When you block the menin, you get the differentiation blockade removed. You get rapid differentiation of blasts, monocytes, neutrophils, and you can see this in the side effect, which is differentiation syndrome, which is a rapid surge of neutrophils, monocytes into the circulation, can go to the lung, kidneys, and other places causing differentiation syndrome. So differentiation syndrome is really an extension of the biological mechanism action of the menin inhibitors. Now, there are many menin inhibitors, 4 of them, the first 4, revumenib, ziftomenib, Blexienzo are in advanced development. The first 2 already approved within the last year, both revumenib and ziftomenib. The next 2, I think, may actually have a better profile in terms of safety, tolerability, PK, azole interaction, and maybe efficacy, but they came 2-3 years later, so we have to wait for the final data and approval. And there's a recent one called BN-104 from Serbia that was developed mainly in China, but now is going to trial in the US, Europe, actually in the next couple of months. So we have a lot of these drugs. The main thing here to remember is, like the FLT3 inhibitors, the menin inhibitors are not the same. They have very different structures. They have big differences in terms of how they bind, how long they retain within cells, the release period. Their PKs are very different from 2 to 4 hours to 50 hours, depending on the drug. And I think all of this will play into how they combine, how they have differentiation syndrome, other toxicities, and we have to look at each one independently in the combination and the development. These are the approved menin inhibitors in relapsed refractory setting. There are 2 approved that I mentioned, revumenib and ziftomenib. Revumenib is approved for both KMT2A range and NPM1. CR/CRh rate is not that great. It's about 23%. Overall response rate is about 45% when you add in marrow remission CRi. So as a single agent, if you want to take patient transplant, it's not a bad option. You get about 50% remission rate. With standard therapies, we have published this about 25%. So it's not a bad option, but as a standalone therapy, this is not that great. If you cannot follow through the transplant, duration is only 4 to 6 months, and you have to work through toxicities, differentiation syndrome, QTC prolongation, which are not that infrequent, almost 10% to 12% grade 3 differentiation, as well as QTC prolongation. So good drugs, but I think we need to improve on them further. This is where we think Enzo, Blexi, maybe some of the future new menin inhibitors, maybe second generation better. We're now starting to see response rates going up, CR/CRh 40, overall response rates 50-70%. Early days, but the data is looking encouraging. And more important than just response, because the number is always small to make these comparisons, we're seeing differences in tolerability. So in general, the 3 key side effects we're seeing in the menin inhibitor class are differentiation syndrome, myelosuppression, which is on target with menin inhibition, and then some of them, maybe revumenib, maybe ziftomenib to some extent, QT prolongation. But with Plexi and Enzo, we're seeing the differentiation syndrome rates, as you can see, are much lower. The grade 3 is less than 10%. QTC effect is almost non-existent. They also have less azole interaction, less PK issues, and so maybe better for combination build.
What do you see in terms of the differential response rates of patients who are been naive versus been experienced with menin inhibitors?
Yeah.
Early on, some of the response rates were much higher.
Right.
We even talked to them about, when the Ben failure patients were coming along, the response rates would go down.
Yep.
Sure enough. So what are you seeing
So in general, it's I don't think we've published separate, but in general, it's lower. There's no doubt it's lower with event exposure. The problem is most of these studies, like which is enzometic, 85% of prior event. You know, the recent Rebu Lexi also 78%. This is probably one of the reasons, and I was talking to Rapid Lunch, that the duration of response of the menin inhibitors is so much shorter than what we got with gilteritinib IVO. So the FDA says, oh, but you know, we're really disappointed because the duration is not even as good as gilteritinib in IVO, which we approved as single agents. And should we have done that? And we said, well, actually, it's not fair. If we have gilteritinib in post-event, we know it's been published, response duration is much shorter. So you're now in a more improved frontline setting where your salvage therapies are going to struggle because you've given such good or better frontline therapy. But yeah, and the reality is today, I mean, if you come to MD Anderson, 90 to 95% aside from the core valvular appeal are getting back with HMA van, with intensive chemo van, AZA van, give something like that. And that's across the country, 70-80% at least are getting van frontline. So that's where we have to see what the data will be. And it's not that good, which is why I think, again, if we're going to use these somewhere, it has to be early on, whether it's frontline or MRD guided or some early on setting is probably where they will be better tolerated and give us the best effect. Now, a little about differentiation syndrome, again, for many of the fellows, residents, you know, even faculty, this is a very tricky one with the menin inhibitors. So if you look at the table, this is a nice paper by Isa, who's doing a lot of our menin inhibitor efforts and studies. We have atrasentan, you have IDH, FLT3, and menin. But in general, the severity and the frequency of differentiation syndrome is the highest with the menin inhibitor, and they have a very different manifestations compared to atrasentan, which is predictable first 15 days, mainly pulmonary leukocytosis. We have seen things from renal insufficiency, acute transaminitis, skin rash, painful lymphadenitis, bone pains, all kinds of things. So we have a very low threshold, high awareness. You see the white count go up. You see some weird manifestation. Then the first one, the knee jerk now is just give up dex for 2-3 days. Today morning, I got an email like this: some days ascites, white counts, a little bit of ups, a little bit of AKI. Everyone, oh, it's like, you know, DS. I said, I don't know, just give up the dex for 2-3 days. We'll figure it out because by the time you know, then they get much sicker. And it's like a diagnostic and therapeutic test. You give up dex and within 24 hours, 40 hours, everything is better. Well, that's what it is. And it doesn't impact the long-term treatment. You can continue with the menin and resume. So we've become more and more knowledgeable that it can be very different manifestations. And then lastly, menin inhibitor resistance. So this is something that is very early. You'll hear a lot about this probably later this year. But the key points here are we are finding mutations. They emerge quite early, and anywhere between 20 to 40%, maybe even 50% we're expecting will have these resistant mutations on menin inhibitor, which will cause resistance. Now, will that happen in the frontline setting when we combine them? We don't know. That's something we have to find out. And the mutations are different for different menin inhibitors. So there's not one mutation that seems to be pan-menin. They seem to be different for each, which of course opens up the idea like CML, that you could sequence or select menin inhibitor based on the emergent resistance. But I think this is something we still need to figure out. And then I'm not going to go into this in detail because it's too early, but there's a lot of combination efforts happening very quickly in the menin field. All of the menin inhibitors are moved into combo with AZA/VEN, some with intensive chemo, with FLT3 inhibitors. I think it's hard to say. For the KMT2A, the data is looking good. AZA/VEN with the menin, both the revumenib as well as the data from our MD Anderson SAVE study, which was oral HMA/VEN revumenib, is looking quite good. NPM1, I think it's too early. So unlike FLT3, IDH, where we are more confident with the data, the durability, survival, the safety, in the NPM1, what we're seeing so far with the Beat AML study as well as our MD Anderson study is not looking clearly better than HMA/VEN alone, because the bar there is high. HMA/VEN alone gives you 24, 25 months. So I think that's the one where we really probably do need a true randomized study with a good setup with NGS MRD, and we're not jumping that the HMA/VEN will be that much better. There is more myelosuppression, there is toxicity, and the bar is high. So we have to wait for randomized data before we make the decision in that subset. But I think a lot of these will happen in the next couple of years. These are starting, and eventually, hopefully, like FLT3, like IDH, this is where they will have the best impact in terms of improving survival and outcome. So I think in conclusion, HMA/VEN is probably going to be used more and more, broader and broader. It already is. It may not be just HMA/VEN. It may be HMA/VEN with a targeted therapy such as FLT3, IDH. These are already moving in large phase 3 or large expansion multi-center studies, which will hopefully get NCCN guidelines and approvals in the next near future. There is an art to giving HNA then. You do have to do a early stop event if you're seeing myelosuppression, use growth factors, use antifungals, etc. It's not a continuous therapy. If you do that, you get a lot of myelosuppression. And then I didn't go into it because it's a separate topic, but there's a lot of data with NGS MRD. And I think in the next 3 to 4 years, that's something we're going to use more and more to decide which patients may not need transplant in the first remission. There's data already for NPM1, FLT3 that may help guide that for KMT2 as well in the future, which patients may not need indefinite therapy, which patients you could give short periods of treatment and stop like CLL. I think that's something we're starting to look at, but it's quite early. And then, of course, there's a lot of immunotherapies, antibodies that are not yet fully primed in AML, unlike myeloma and ALL, but are coming in the near future and will further, help for the non-mutational targeted frontline patients. So I'll stop there and, happy to have any questions and reach out to me anytime. Thank you, folks.
One joke, I think all of this was new from my fellowship, which is about 10 years ago.
Yes,
absolutely. Some of the part about steroids, the utility of steroids across all medicine stuff.
Actually, I say that to many fellows. I said, what I'm most proud about is I'm not going to show you a single slide on 7+3 or the dose of guanarubicin and cytarabine. Like people, there's a whole talk on guano 45, guano 90. I'm like, that's what I'm not going to show anything about. Yeah, so that's good for us. Yeah.
Anything promising about 53 medicated business, or what would you do if trial-wise or spin?
There's a lot of trials, In fact, for us now in the relapse, this is like almost 40% of our referrals. It's very very depressing because there's nothing great out there. From a hypothetical view in biological, I think immunotherapies are going to be what will work there, at least to improve the outcome. I think cure is very, very, very far for TP53. Whether these will be based on NK cell therapeutics, CAR T cell therapeutics, monoclonal antibodies, bispecifics, we don't know. But there's nothing today on the horizon, even at phase 1, I can say that is showing consistent clear activity. There's drugs, we're working with tuspetinib in the frontline setting. There's some early data we showed at ASH that there's good response, but we need durability. There's drug pivekimab, CD123, where we have shown with AZA combo that it's quite safe, not very myelosuppressive, and there's activity in TP53, but survival is still about 10 months. So that's just a tough. What we're actually starting to do, I would say, in our practice, we're working very close with our transplanters. So what we realized is the only patients who have cure or at least beyond 2 years survival is those we can get to transplant quickly. And even then, it's only 20-28%, but it's there. We have 10, 12 patients now who are beyond 2 years post-transplant, biallelic TP53 and like some have GVHD other issues, but we're making it. Will they stay 5-10 years? I don't know. So what we're doing now is we get them, when we see them, we get the transplant team and we have a rapid transplant program now. The goal is within 60 days to move them to transplant. So whatever you choose to your frontline, AZA then CD123, or that alone, depending on the age. If they're a transplant candidate below 70, 71 usually, we're going to try to move into transplant, ablative, do early withdrawal of immunosuppression. We're planning prophylactic DLIs 2 to 3, they can tolerate it, and then do maintenance. So kind of like a total kitchen sink aggressive approach. And we started to see a few patients, in the last year who are more getting transplant. So we looked in 2018 to 2023, our transplant rate for TP53 was 9%. So everybody says we want to transplant, then not transplanting. You give 4 or 5 cycles, they have infection, they get very sick, they get hyperinflammatory, they get HLH, they don't make it, they lose response. So now we're getting about 35%. So at least getting them to transplant, we're achieving. And hopefully we will start seeing some of those get more durable. But there's no amazing answer to that, right?
Do you folks have a bar for VAF clearance or cytogenetic response, or is it still the classic?
So far, no, but there's always rumblings from the transplanters, right? So whenever their numbers start looking bad, and they get to the point of the, transplant, so then Popat and Chabal will call me and say, oh, we gotta slow down. Because, to their credit, I have to say, and I've talked to many, many groups across the country, they are very, very good at transplanting and very helpful, especially to young patient, even Savage. Now we have the benefit that we have these big numbers, so we can buffer it. Because we take a lot of FLIP-E and take an ideation, that so the numbers were good. But then if we start doing too many TP53 recon, then they said at some point we have to be careful because obviously we don't want to do degradation, which actually happened like 8 years ago at the Anderson, which is crazy. So they had 9 transplant centers in Texas that were recommended, not in the Anderson. All of them were like less than 20% our size. So
That's the IDMTR, so.
or this was actually the Blue Cross Blue Shield insurance. Yeah, based on the CIBD score, which is, I don't know, there's a big problem. That score is not accurate.
I have a lot to say.
Yeah, it's not, even the first show was there at the meeting and we just, that needs to be revamped. It is completely a disservice to patients because then transplanters, even they want to help, they're like, well, we cannot afford to take third relapse to 30-year-old DBP because they're gonna pull our score down and like the score does not account for a lot of these variables. So
We've actually added PVD as a high risk criteria, just so we actually really scrutinize that patient.
Yes.
Everything has to be perfect.
yes,
Like you said, we're like a small meeting program, so we can't, we're not
No,
really
I know.
counting them, but.
Yeah. It's a realistic problem. Yeah,
Yeah,
it's a big problem. That score hopefully will be revamped. Yeah.
So in the TB53, what we all ate today, it was about 15% MRD negative. What is with the triplets now?
So I don't know the MRD. I know the CR/CRI rate was over 41%. The true CR rate was only 20%. MRD is probably 15-20%, sounds reasonable, it's low base. And the survival was 7 months, 6.5, 7 months. So
What
that
about
was,
on the triplets? Is it that MRD negativity rate?
it depends, isn't it? And that's what I was talking about again. The MRD is not very predictive in TP50. So the ASIN and PVEC we just presented ASH, so we put all the data together for the phase 2. The MRD negativity is very nice, actually in TP50 it was like 80 something percent. But then the survival is only 8 months. On the other arm, it's about 80-85%. Survival is like 20, 30, 23, 24 months. So TP50, I think I don't, because an aggro, we have like PTSD from that.
Yeah.
So I don't get excited until I like see survival. And then, but I think it's a combination of safety. The drug should have really limited added myelosuppression because these patients are already high infection rate, high myelosuppression, good efficacy, and then eventually, hopefully, allow patients to get to transplant safely. And then maybe we will see, even 12, 14 months is probably a first good goal. I mean, talking, cure and all these way out there, but even if we can get to 12, 14 months, 20%, 30% with durable cure, maybe, or 2 year survival, that would be a nice first step.
Yes, you see some connections with myeloma, what that looks like. I think one of the things about myeloma is that the drugs that they have available are very different mechanisms of action. Antibodies, NSA therapies, proteasome inhibitors, demodulators. And I feel like even with our targeted agents, all the testing these initial modalities, are we seeing hope for cellular therapies in AML or for antibody-based therapies in AML? Could they become quadruplets and things like that in the future?
Well, 2 questions. So yes, in fact, a lot of the research now that I did a lot of the FLIP3 and other things and we're doing that, but my focus really more is now the immunotherapies, because I think that is what will move AML to the next level, like ALL and lymphoma and myeloma, right? So there are ADCs. ADCs have always had kind of a reasonable success and activity, not blockbuster, but they have single agent activity, they're reasonably tolerable. So I think the next on the near-term horizon that I think has a good chance is the CD123 ADC Pivekimab. Is going to be approved hopefully for BPDCN very soon. The FDA is reviewing it. And then their AbbVie is now acquired it and they're planning to do a larger registration study in AML. And we've used that drug for 5-6 years, many patients. It's very safe and well tolerated, no capillary leak and all that. So I think that is in the next 2 to 4 year time period, maybe the ADC that will get added to the AML frontline, HMA then and other settings. Long term, yes, cell therapy is what, but as you know, there are so many challenges. The antigens are so promiscuous in AML, they're expressed on monocytes, they're expressed on hematopoietic stem progenitors, they're expressed in liver, endothelial, all of these problems. So we've tried it. We've added like 5 or 6 different CAR T, logic gated CAR NK, just in the last few years. And because of toxicity most of the time, even before we can get the efficacy, they are struggling. So what I'm quite, there's a company called, there's Arcelix is one of the companies, and there's another one, Adenson out of Germany, where they're using this kind of protein module that kind of helps to gate the binding of the CAR. So it's kind of a three-way protein, when it binds to the native antigen CD123, then it binds to the CAR on the other side, and when you have all three together, then the CAR is activated. Otherwise, the CAR will just stay in circulation. The advantage of that, and it's a 1 hour, very short half-life protein, is that if you run into toxicity, monocyte activation, CRS, ICANS, severe myelosuppression, you can stop doing the protein, and then you can get the drug out. So we've treated a few patients with that. We've had some good responses early days, and I think something like that, or even more innovative, which nicely in CAR is happening every 6 months. There are more innovative things. But yes, I think, will it happen? The answer is yes. Is it going to be 1 year or 5 years? I don't know, but I think cell therapy will come again. Yeah.
Only question going. It's an online question. From Amanda Kagan. She wanted to know if you could speak a little bit more about how you dose then in practice at MD Anderson. Are all patients ramped up to 400 milligrams daily? You give posaconazole, and then what do you do with the then? You dose at 100 milligrams or less. And you limit the course to 7 to 14 days, depending on the NGS results, once you have them back.
And that is a very, very good question. So a lot of this actually, that we do speak in that how I treat article, but from a practical point, number one, POSA and VEN is a very tricky combination. So our group is, Kapil and our group actually did a very nice pharmacokinetics work with Yitesh Kovaria, one of our PharmDs, where they looked at 100 patients treated with Aza-Ven with different azoles, POSA, Vori, Cresemba, and no azole. And what we found is that, no azole, Cresemba, and Vori had very consistent VEN levels when you use the appropriate dose reduction. But POSA, even with 50, is all over the place. Some people are getting equivalent of 800,000 VEN, some are getting low. And this is actually data that others have started. Andrew Way had a similar experience as well. So in general, for most of our frontline patients, especially since they come from across Texas and the country and far away, we admit them. I mean, they're not living local, it's hard. So we say, we'll admit you. And we usually are starting with Casco, pungent, because that's the easiest one. We do the ramp up then, so we do 100, 200, 400. And then we usually keep them on Casco since they're in the hospital for that initial 2 to 4 weeks. And then by that time, they have completed their VEN, hopefully they're in remission. Then we will start the antifungal, because you also want to start the antifungal a few days before, right? That's the other issue. If you start POSA and VEN 50 together, you're probably getting VEN 50 because the POSA has not achieved the level to impact the VEN. So this way it gives us time. We usually do VEN 21 days to your second question. HMA VEN, we're doing a bone marrow around day 21, 22. If that marrow shows less than 5% marrow remission or ablation, we stop the VEN. Then we let the patient go outpatient, give time for count recovery. We're becoming more and more proactive to use Neupogen. So usually we used to wait. Now after day 21 marrow, the ANC low, the marrow looks clean, we give Neupogen. Then we start them on an azole. I am more in favor of Vori and Cresemba. That's what we have used. Many in our groups will like POSA, and in general I like POSA, but with the VEN, I think there's an issue there. A lot of studies are showing that. So Casco for cycle 1, 21 days VEN, bone marrow end of day 21, stop if achieved remission or marrow clearance, use growth factors, and then cycle 2 onwards, start them on Vori or Cresemba a few days before, and then most of the subsequent cycles we do outpatient. So yeah.
I think we're at time. Thank you again for coming and giving Grant a talk.
Thank you. Thank you so much.
Yeah.
I'm just kidding. Thanks for having us. Thank you.
Yes.
I
think it was it.
That's just one. Okay. I think it's
I'm on this one.